All right, hello everyone. Our debate topic is restraint and seclusion, and we'll start by introducing ourselves.
Hi there, my name is Alex Beelish. I'm from Chicago, Illinois. I have around 4 years of ABA experience, mainly working with kids ages 3 to 10. And in regards to restraint and seclusion experience, I've been in a few restraints myself and have experienced other coworkers restraining individuals.
Hi, I'm Brittany York, and I'm from the Indianapolis area in Indiana. I have about 2 years of ABA experience, and I've worked with kids ranging from 2 to 14. And then I also work within schools doing ABA with kids who have multiple diagnoses. I've had different restraint and seclusion training procedures and have used it in both the school and clinic setting.
And hi, my name is Hannah. I live in Pittsburgh, Pennsylvania. I have 2 years of ABA experience and 4 years of experience working with the ASD population, and so 4 years of experience using the PCM restraint procedures. I don't have personal experience with seclusion.
Hi, everyone. My name is Heather. I live in Washington, D.C. I've been working in the ABA field for the past 10 years, first as a tech and then as a BC ABA. I've had some experience doing restraint at certain schools and residential programs that I used to work at.
All right, Allison, I think this is your introduction. Is anyone able to hear me?
I
I can.
I can hear you.
It says she's
says
muted.
Allison muted.
Sorry, I was on, for some reason it muted me.
Okay, go ahead.
But okay. Hi, my name is Allison Bryant. I am from Houston, Texas. I have 3.5 years of experience in the field of ABA, and I have some experience with restraints in the clinic that I work in.
All right. So just to quickly overview the topics that we are going to be discussing today, we're going to go through definitions of restraint and seclusion, effectiveness, the risks associated with restraint and seclusion, how we can think about restraint and seclusion in different settings, and then some alternatives to using restraint and seclusion.
And so the kind of style of our debate will be pretty informal. We will have main topic questions that will be asked and that will structure the debate. We'll provide research that supports different points addressing those questions. And then we'll just open up the question to a larger group debate.
Awesome. So to get started, the first question that we are going to be discussing is, how is restraint defined, and what are the types of restraint, and which are most ethical to use?
So the Law Dictionary has a legal definition of restraint, which is prohibition from action or holding or pressing back action. What do we think of this?
So that definition is quite broad. Like, for example, would a baby gate be a form of restraint? Or we could even think about, what would it be like if we were using a protective mat to block against aggression, or arm guards to prohibit things such as SIB, like arm scratching? Like, would that be considered restraint in some scenarios?
Maybe a good way to think about it is restraint is often broken into 3 categories: mechanical, chemical, and physical. And we have a visual for this. Here we can see the physical or the mechanical restraint holding the arms in place to the left. We see the physical prone restraint in the middle, and then chemical restraint, which is also a form of restraint in some settings. So a lot of people consider a baby gate seclusion. They consider it a form of mechanical restraint. That's because they often think of seclusion as a form of mechanical restraint. There is another graph that shows, sorry guys, using a protective mat may also be a form of seclusion if you're blocking somebody into a place where they can't leave, or it could be a physical restraint if you're holding them in place and restricting their movement. Chemical, like I said, is often used in like medical settings or something like that. The next graph shows how common different types of restraints are. You can see from this graph that physical and unknown are the most common. After that, mechanical, very little popularity. Chemical is used a bit more. Seclusion is included as its own type in this example. All right. But it's often debated which of these restraints is the most ethical to use. So we can start talking about that.
Right, and I think what's most interesting is the fact that within this graph that we have is that physical, non-prone physical, is so widely used, but there's such a debate on whether it is ethical to use in situations at all, or whether individuals should work within different systems or intervention types.
So something else to consider, which just kind of changes up how we define or how we might look at restraints and seclusion, is the fact that legally restraints are often viewed as corporal punishment while in a school setting. So the ACLU has a definition of corporal punishment as any punishment in which physical force is used and intended to cause some degree of pain or discomfort. So I think even though when we think about how restraints or seclusion might be used in a school setting, we're never trying to cause children or individuals pain, but it is meant to sometimes be uncomfortable or cause discomfort. So I just think it's interesting to think about that definition. Like legally, it's corporal punishment, which can also bring up a lot of thoughts around that. And also to think about the fact that corporal punishment is allowed in 20 states, but the ACLU and other researchers definitely have shown that corporal punishment has been found to not only be harmful, but also possibly leading to an erosion of mental health and can sometimes lead to increases in aggression and violence and problematic behaviors. So this is Brittany had said she wants to talk about the BACB Code of Ethics and talking about least restrictive alternatives and how locking someone in a room alone does not seem to be a safe or least restrictive alternative. Do we as a group agree that physical or other mechanical restraints should be chosen over seclusion when possible?
Well, a randomized control study by Steinert, Burke, Flammer, and Berg did show that seclusion actually produced less PTSD symptoms a year later after its use than mechanical restraint did. So that is something to consider because there weren't any hands-on. There's a possibility that less traumatic experiences occurred. There's also the idea that, it's true, physical restraint is known to cause injuries and even death in some cases. So considering these factors, seclusion may actually be the least restrictive.
Right, and that's really interesting because a lot of the times people see seclusion as this really unnecessary aspect of intervention, yet with the research that we're seeing, it may be least impactful in comparison to some of the other restraints. And a big thing that connects to this is the fact that a physical restraint may be least restrictive as well, though, right? So we kind of have this mix of ideas based on research and also just social validation of the interventions out there. We've actually seen that physical restraints can actually be therapeutic for individuals, and it sometimes, even though it may be seen as the last resort, it is very common and necessary for some individuals. We know through the PCM restraint system, they state that feedback provided through fading and intensifying holds when needed actually is relaxing for individuals. So with that, you can actually shape desired behavior more effectively, and you can have a child removed from the restraint more quickly in the moment. And this will teach the student that certain behaviors will allow them to safely escape the restraint in the future. So there are systems that allow for a safer way to work through things like aggression or self-injurious behaviors. And sometimes it just takes time for these individuals to learn about that.
Yeah, so there may be disagreement in deciding if the physical restraint or mechanical restraint is the form of seclusion or is least restrictive. However, chemical restraint could be considered the most restrictive. So several issues with chemical restraint include staffing and medical resources, needed negative side effects, and overprescribing.
So we have a few questions within this topic too. So just a few general questions that we'll open up to the group here. So based on our personal experience, what type of restraint do we think is the most or the least restrictive? So let's start with the most restrictive. What do we all think about that?
I mean, I think it's clear from just like the research that everyone shared and brought to the debate that I at least think that the chemical restraint is the most restrictive. I don't know. How do you guys feel?
I would agree that chemical is the most restrictive. I feel like it's not therapeutic in any way. It doesn't allow the person in that type of restraint to learn or make changes in the future. And additionally, like it has many negative side effects, like people that are in chemical restraints aren't able to make choices or to have any sort of mobility in that instance.
Yeah, I definitely agree. The mobility aspect is a big feature. I mean, I could see chemical restraints honestly just turning individuals like zombies, and at that point, it seems like it's way too intense, regardless of the behavior. And the research that we're seeing, it seems like there are better alternatives that can be less restrictive.
Yes.
Okay. So it seems like chemical is kind of our agreed upon for most restrictive. What do we think about the least restrictive restraint?
I think it depends for the individual, which I mean, I think there's so much that like in the world that we could say, oh, it's very individualized. Because I know just like in the research that's been discussed in this first section of the debate, there's already been things that maybe don't contradict one another, but like there's differing sides. So some saying that some physical restraints can be therapeutic for others, while there's other research that says that physical restraints might cause like more aggression or like a deterioration of mental health. So knowing that like there's some individuals where a physical restraint might be therapeutic and some individuals where that's really the opposite of therapeutic, and same for seclusion. So I think it really depends on the person and the behaviors and also the resources of the facility following through on that behavior plan.
I agree with that as well. I do think it depends on the individual and the resources of the school, like you said. Like if seclusion is not a something available in every setting, and that's something we might get to later is discussing settings. But in that sense, like seclusion can't always be reliable. But also, I do think that there's something to say about physical restraint being least restrictive because it is offering some sort of a therapeutic option. It is teaching the learner over time what behaviors are able to grant them more agency in their environment. So where seclusion, I don't see that there's an active or immediate ability to fade that restraint over time or in the moment.
Sure, and you know, I think that really also connects to the type of restraint they're using. So if we are agreeing that physical restraint is least restrictive or seclusion can be a part of that as well, I think it really depends on what type of restraint, what type of seclusion, because like we're saying, with settings, with different environments and different behaviors, that may change drastically. So I think there is a lot of gray area within this topic, but I do overall agree that physical restraint and possibly even seclusion as a whole can be least restrictive in comparison to like chemical or mechanical restraints.
I think this brings us really nicely into talking kind of about when restraints and seclusion can be found effective or when they've been found most effective.
Sure. So I know from the research and looking at effective training, we're seeing that there's a variety of clinical organizations that use restraint and seclusion training programs, and that's to ensure the safety of staff and clients first and foremost. So a lot of these trainings focus on a variety of topics. It's not just that they're teaching individuals to hold clients down. They're teaching them de-escalation techniques. They're teaching them alternative types of restraints. And I know that's a topic we'll touch upon later is, what things can you use in conjunction with restraints. But this training is really important because, like I said, it works towards the safety of everyone involved. There's been a lot of increasing evidence that seclusion and restraint work most effectively when you have positive intervention systems in place. So there really has to be a heavy emphasis on that fact. And we are seeing that with a lot of training programs nowadays. And it also connects to the fact that within these systems, ethically, we should be utilizing the least restrictive treatment available. And I know that still might be debated upon. We talked a little bit about the least and most restrictive restraint techniques and how that may differ, but that's why we have to look at things with a case-by-case basis. But regardless, the ABAI, the Association for Behavior Analysis International, they support the use of restraints and seclusion when it's ethically planned, predetermined, consistently monitored, and consented to. So ethics plays a large part in any type of restraint. In addition to that, there is an article by Luesi, Sperry, and Draper from 2015 noting that restraint methods that are effectively trained, closely supervised, and analyzed within their data can show effectiveness when utilized. So you have to have a backing behind the restraints used. We're not just using them willy-nilly out of the blue. And so there was some information from the CPI. They have a lot of graphs, a lot of survey data from different companies since they are a very large training system. And they've seen great reductions in school settings. They've seen reductions in hospital settings. The one up right now is from the Aspen program, International Institutional Service Schools, and they saw a really large reduction from the 2014-15 school year to the 15-16 school year, a pretty large drop there. In addition to that, you also have healthcare settings that are making staff feel more confident and secure, and it's actually leading to the reduction of restraints as a whole. So the training behind restraints really matters. It can really impact the clients and the staff and their overall safety. And then Brittany, you can probably, it's Brittany here, Schiller now.
Hey, skip over me on this part real quick.
Right.
Sorry. But I will talk about that stuff when it comes up in the actual presentation. And I think it's helping for us to kind of outline as we go. I'm trying to add names of who's saying the stuff.
Yeah, I'd be cool too if we broke up what I just said, if someone else wants to take a few points.
I think that we should break that up. I agree.
Yeah, because it's a little bit too much.
Okay, cool. So skip me. I'm sorry.
Okay. So we can just pretend we talked about those,
blah, blah,
give it
blah.
like an extra minute, yada yada.
Yeah, that's so interesting, Brittany.
Wow.
On to the next. I thought it might be a really good idea to now talk about the social validity of restraints. There was a really great study done by McDonnell and Sturmy in 2000. Basically discussing the fact that physical restraints can be not only strenuous but also emotionally arousing and difficult to maintain. The study that they looked at in 2000 was observing the difference between floor versus chair restraints in relation to social validity, which is like how accepted these interventions are. Participants had to view videos of 2 floor restraints and 1 chair restraint, and then fill out an evaluation survey to compare the different interventions and what people thought about them. the people who participated in that study were special education professionals, residential care staff from hospital settings, high school pupils who, have no experience with developmental disabilities at all. And at the end of that study, it was determined that the chair restraint was judged far more favorably than the floor restraint. So I think that's really important to notice that not all physical restraints are equal. So we can talk about physical restraints being socially valid or not, but also knowing that there's different types of physical restraints, and some are going to feel more socially valid than others. And
Heather, why do you think that is, that people viewed those so differently, or what are our opinions as a group as how those are different?
Yeah, I was just thinking, like, this study really shows that having a restraint done in a chair versus on the floor, people felt that that was more socially acceptable. And I used to work in a school where there would be, some kind of more what we might think of as like gentle, more mild restraints, like one person like basket holds, or helping escort a child from one place to another. And like that felt a lot more socially acceptable than when it takes multiple staff holding one person down. So I think things like that, going back to our definition, I think the fact that sometimes restraint can be defined as corporal punishment, that means that as a society, we view like having to restrain someone as somewhere like on an iffy part of our moral compass. So I think that makes sense that this social validity study showed that maybe more intense restraints are viewed less socially acceptable.
Right. And, I just think of, go on.
Oh, I think that's interesting, but do you know if there was any information about which restraint is actually safer? I feel like being restrained in a chair would actually cause more of a safety risk, because there are like, immovable, unbendable objects being used that could cause harm. Do you know? I just wonder if anybody knows.
That's actually a good question, now that you point that out. And it's interesting because with this study, I know that they always favored the floor restraints, and I guess it depends on the environment too. And it can also depend, are these chairs using straps, or are they just being held by other individuals? But I definitely see how that can be an issue depending on the environment.
I guess just personally, being someone that has experience with restraint, I would find that a floor restraint was more socially acceptable than a chair restraint. How do you guys feel, since you also have experience with restraint?
I mean, I can definitely say just from the training program. So I've done CPI, I've done TCI, and Handle with Care. Typically, when you see a floor restraint, it is seen as unacceptable. And I think it's because you see a lot of aggression with floor restraints because they're very uncomfortable. I know within the training program that I went in, as soon as you're in a floor restraint, you do not want to be in it. You want to stand up instantly. And I wonder if the chair might be a more, favorable position, sitting rather than half on your chest, being held up by someone.
I know that I've done both floor restraints and chair restraints. I've been trained in both. And I definitely feel like things like Alex said can become, I would say, more to handle on a floor restraint, whereas in a chair, there seems to be a little bit more control. In the sense of it staying calmer, like giving more guidance to the client's body, where it can become more of a wrestling looking situation when you have that restraint occurring on the floor.
Right.
And I agree. And I wanted to just make up the point that, kind of like I had said in the last section, that it's so individualized. Like, I know in the past when I've been in a classroom where a floor restraint had to be conducted, one of the first things that you do is like make sure that the area is clear, make sure there's a mat down, and that like usually involves like moving chairs away, because they can be like, they're made of metal and it's hard, and you don't want anyone to accidentally like move something. So I think, but if there's like, I don't know, a child where a chair restraint makes more sense. So I just think it really depends on the circumstance and the child. And again, going back to the resources of the school or the clinic setting in which the restraint is being done in.
Heather, you bring up a good point as well about the resources, because you have to have a different size chair depending on your size of client. We
Right.
had to have various chair sizes available at one of my previous clinics, just because we had some smaller kids that certain chairs were not appropriate for them. Also, you couldn't have rolling chairs. So trying to find the correct chair or having someone bring it to you at the time can be difficult. And you're posing a risk to the client if you're using a chair that isn't appropriate for the chair restraint.
Sure.
Very interesting. Yeah. Yeah, I don't have any experience with chair restraint, so that's eye-opening too.
Right. And neither do I, but I just think about, I've gone through some basic intervention programs where we're having a kid sit down or having them work at a table. And, I've had times where those individuals don't want to sit at that table. And I've seen it where, they can flip over the chair and almost bang their head on the wall. So I wonder, in an aggressive state, in an environment where things are out of control, what can happen with that, right? Maybe it can help the client's body to stay, like we were saying, more in line in a certain pose. But I wonder if it has a more of a dangerous potential in the end. So, I think we had some really good points brought up here about different types of restraints. And as a lasting question there, how do we think social validity impacts the training that occurs for individuals? Do we think that when something is seen as more acceptable, there's more training on it automatically?
I almost would say the opposite. I think that sometimes we spend more training time on those things that can be controversial to the community, so that when we do use it, at least at my clinic, and I feel like the clinic I was at before as well, that when we do use it, we're using it with the most fidelity that we can and in the safest way possible, because you are risking doing it incorrectly and causing harm if you aren't doing it correctly, which definitely would not be acceptable to the clients or the community, or to the clinicians for that matter.
Yeah, I agree with that. And I think that that is a good practice. I think that that's probably the way it should be.
Right. All right. Well, I think we brought up some good points there. Again, just talking about the different types of restraints, some effectiveness. But I'd like for us to move on now to our next section, which we'll be talking about the ineffectiveness. So what characteristics do you think contribute to restraints or seclusion being ineffective within various settings?
Sure. I think one of the main characteristics that contributes to ineffectiveness for restraints and seclusion is a lack of training. Training on restraints and seclusion certainly differ from program to program and institution to institution. So it's really important that these differences may dictate whether a particular restraint can be used effectively. I also think it's really important to note that physical restraints can often function as positive reinforcement for some people. And that means that the restraint might be maintaining rather than decreasing the target behaviors. And I think, proper training is going to also help with that as well. Like if these restraints and the behaviors in which they're trying to target are not really adequately being like the data for them isn't being tracked, and someone's not able to look at the data and say, hey, we implemented these restraints and the behavior seems to be increasing. If there's not someone there to say maybe we're maintaining rather than decreasing the problem behavior, that lack of training is also going to contribute to an ineffectiveness.
Right. So the lack of clinical observation and data analysis also, many people with severe problem behaviors can be effectively treated without the use of any restrictive interventions. So therefore, restraints can be completely ineffective when they are not really when they're really seen unnecessary to utilize. Also, the use of crisis management as a behavioral treatment plan. The ABAI states that crisis management programs should not be a replacement for behavioral treatment plans. Restraints, seclusions should be used as a last resort, obviously.
Right. And I think that connects really well to lack of training. It's not even, what are you being trained ineffectively on? It's what are you being trained on that shouldn't happen, right? So like Allison said, if something's ineffective, if it shouldn't be clinically used and people are using it, why is it happening, right? What part of the training broke down there, or what part of the training is being forced on the individuals that shouldn't be?
Yeah, the research had talked a lot about a lack of training being an issue, but there were several other things that played into it. There being a poor supervision of staff that are, even the clients not having clear expectations of what they should be doing could lead to more restraints and seclusion that isn't necessary, and then you get into more of the issue of it being ineffective if they don't have clear expectations, they're not understanding the purpose. Leading into as well staff not understanding the expectations or procedures for restraint, not having clear definition of when a restraint should be used. So then it's not being used consistently across therapists, for instance, or different staff members within a school or detention center. There was, research talking about a reporting system being in place as decreasing the number of restraints and seclusion needed. But when there was a failure in that reporting system where it wasn't in place, then, we have that chance again for ineffective restraint and seclusion being used.
Yeah, that's really interesting. It really emphasizes the importance of being technological when implementing restraints and seclusion. And ABA tells us all about the importance of that as well. Is there any other comments on this section about the ineffectiveness of restraint and seclusion?
No, I think we covered it all.
All right, let's move on. The next question is, what are the risks associated with restraints and seclusion in schools and other settings?
Sure, I can take that. So, a lot with the research that we've talked about, with that effectiveness and ineffectiveness, we have these different training programs, and a lot of them still have flaws that cause high levels of stress, they cause injuries, they cause staff turnover. And unfortunately, sometimes we see the death of staff and or clients. We're seeing that from research articles. Singh et al. 2015 notes that highly. And you're seeing that a lot of care providers, they're actually susceptible to misapplying physical restraints, and you can also see deviations. It's also known as procedural drift within protocols, right? So individuals are deviating from what should be applied, and we talked about that in the last section. That's how we get ineffectiveness when training isn't applied effectively, when training gets changed, and with that you have a large issue, not only ethically but legally for individuals, companies. You have lawsuits that could come up, especially in relation to death. So there's a lot of issues that are going on with these programs, regardless if it's in schools, hospitals, or other settings.
Yeah, and just kind of to piggyback off that, there's been a lot of reported cases of just rampant misconduct. The National Disability Rights Network reports that there's abuses cited in almost 50 examples from 38 different states, mistreating disabled children in public and private school settings. And I mean, some of these are pretty rough to hear about, but some of these examples include like denying children food, forcing them to sit in their own urine, locking them in makeshift seclusion rooms, breaking their arms, and of course, some children dying during the use of physical restraint. So those are all just like kind of like worst case scenarios that we hear about, but also important to keep in mind when we think about like what happens when this isn't, like what are the risks? Like what do we need to be keeping in mind when a school or a clinic or even us as practitioners decide that we think it's important to implement restraint specifically in our intervention plans.
Right. And I just think that shows that, a single deviation can lead to something like this. And we might not think of that right away, but we're seeing this in the research that, people are dying, people are being forced to sit in their own urine, their arms are being broken. It's really impactful things, right? That this is a slippery slope that no one should go down.
Yeah. They're seeing in juvenile detention centers between 30 and 70% of the individuals that are going into the juvenile detention centers are those that have disabilities of some sort. There's not appropriate programming, and then we get into them using restraint and seclusion without any positive teaching opportunities in place for the kids. So, it's not very effective strategy, and you run into some risk when you're not teaching kids to appropriately deal with their emotions or giving them that replacement behavior, and we're instantly going into a restraint and seclusion options rather than something that would, give them an opportunity to change their behavior in the future.
Sure.
And that, goes back into our training. If we don't have staff, and it ties into resources as well, like we don't have the staff or the resources to provide skills groups or things of that nature, we kind of get in this cycle of just secluding kids or restraining them
Right.
Without other alternatives.
Yeah, and I think it's just really fascinating that we're seeing this within multiple settings, because I feel like a lot of individuals may think, oh, it's a juvenile detention center, of course that stuff happens, but we're seeing this in detention centers and schools, right? There are different environments where these same things are happening, and it's shocking to hear, but it's truthful. It's something that we have to really figure out.
Yeah, I think it's really interesting to look at the data, though, of, like you said, people will think, of course, it's happening in a juvenile detention center. But when you compare our schools to our juvenile detention centers, we're seeing our kids that are in our, life skills rooms, our kids that are being diagnosed with ASD, or severe mental health issues, cognitive delays. Like those are a high percentage. They're saying, looking into 70% of our population in the juvenile detention center. So it's concerning that our instinct is to go to restraint and seclusion for this population of kids.
Right. So I guess I'm wondering, with all that, with the risks that we're seeing in different settings, does anyone have any experience personally, with these risks? Have people seen, hopefully not anyone dying, but has anyone seen a child become greatly injured? Has anyone ever seen staff members become hurt? Because we have different experiences and settings that we've all worked in.
I know that personally, I actually have experience working in a juvenile detention center, and I was not required to do restraints. But the thing that I guess I found most concerning was the anger that the staff was feeling when they were using a restraint. In ABA, you're taught to be neutral, and you have the training to know how to handle behavior with a neutral affect. And I feel like it's very, when that happens, you're just in like, how can I keep kids safe? How can I keep others safe? In the juvenile detention centers, it was very different and more of a responsive fear. Ellis talks about that in his research, and so does Cowles, that there's this need for more training with the staff because of the fact that the staff were reporting legitimate fear if they were not able to use restraint and seclusion as an option. So I think it gets into also that, back into that importance of programming, because when you're putting a kid in a restraint out of fear and anger, the likelihood that that child is going to get hurt greatly increases.
Sure, most definitely. Has anyone else had any other experiences where I guess a restraint wasn't necessary, but it occurred?
I've had an experience not exactly like that, but it stood out to me, and this was probably like 8 or 9 years ago. At the very first school I worked at, that was an ABA school. There were certain classrooms in which restraints, particularly floor restraints, were used quite frequently for particular students. And I remember a staff member saying something along the lines of like, after a particularly long restraint, saying something about how like it was good that had happened because it had been like a really boring day or something, and like that, kind of livened it up, and it made me realize that there was something reinforcing about doing restraints like for that particular staff member. And like I said, like that's just stayed with me this whole time, and kind of stood out as like a particularly interesting and weird pattern of behavior that was involved. I don't think everybody felt like that, certainly, but I think that's like a risk that maybe didn't come up in the literature, but something that I personally had experienced. And beyond that, I think the one that I have experienced that we did mention from the literature was just like the high turnover and like the high levels of stress and injury. I know like I and other staff members have had, you know, probably minor injuries, but just like scratches and like a ton of bruises from different aggressions and like that were occurred during restraints. So like just like scratching and things.
Right.
So I don't know. I guess for me, they were quite low risks that I've experienced, but still very prevalent.
Sure. I know I had an experience in a past residential facility where a staff member had to restrain an individual, and it seemed as if that was the only way they thought this individual would calm down. And I'm not sure, you know, it makes me think about the intervention strategies used, especially with all the topics that we've talked about here. You know, do some kids absolutely need an intervention, a physical restraint to be able to get back to a baseline, right? Or are there always de-escalation techniques available? Are there other ways to handle it? And I'm not sure, you know, what the answer is, and perhaps it depends on a case-by-case basis. I don't know what you guys think about that.
I definitely would agree with you in that it's case by case. You know, I think we're kind of coming back to that in each topic. We kind of end up coming back to, which is important because in ABA and in the ethical code, like everything should be individualized to the client. And so I think that's kind of points out why the BACB set forth that ethical code and stating that it needs to be individualized. Because in all the cases and experiences we talked about, it was so important to look at that individual.
Yeah, I think that's a really good point.
All right.
All right,
And so real quick, Allison, so I don't know what's in your background, but it's echoing really hard
It's
when you're not talking. Yeah, something's in there. I don't know.
I have a fan on. Maybe that's what it is.
It might be the fan.
Let me see. I don't hear, like, I don't know what else it would be.
Yeah.
Y'all hear it now?
No, I think it was the fan. Okay.
Yeah. Okay.
Okay.
That's better.
So I was like, what is that?
Yeah.
You're good. Okay, so you can start the next question. Sorry.
Okay, no, it's okay. So, you know, as we all know, since we all live in different, you know, areas, you know, restraints and seclusion can vary from setting to setting. So what do y'all think? Do y'all think it is ethical to use mechanical restraints as a way to address behavior if it's not something that can be used across various settings? What is y'all's opinion on that?
I personally think that you can end up in a tight spot to say those kind of all or nothing situations. So like, well, if we can't use it here, should we just never use it? I think there's appropriate times to use restraints, but at the same time, I wouldn't personally be comfortable saying, hey, if you can't use this in every scenario or in every setting or with every client, we should totally take it off the table. Some of those things I'd say look back at the research of like, when has this been effective? Can it be effective for some clients in some settings?
Right.
Yeah. Well, while that is true, I do think that like it is totally possible that a client could like have it in their plan that they should be put into a floor restraint or seclusion. But like those procedures, like I worked in Minnesota for a couple of years and floor restraints are illegal. So that wasn't an option that we had. And I know that some students came to our school that were used to being put in those procedures and they spent a lot more time in seclusion because of that, I think. And also, I think it's just important to think about the logistics of not just like state by state, but like in some settings, it's really difficult to implement seclusion because you're out in public. Like there's no seclusion room there. Like I think that when you're making a plan, you have to be thinking about all the settings in which that client will be experiencing. For example, I worked with a client who was a self-induced vomiter. She would vomit to the point of like losing enough weight that she had to be hospitalized, and she would vomit after each meal. And so due to that, and because it was like at least partially automatically maintained, like we were on the fence, but we did decide that like restraint was a good option for her. but we didn't know what to do because the family did not have the option to restrain her at home because there was only one caregiver with her, and she required two-person transportation procedures. So, and then with that happening, there was a variable reinforcement schedule happening because sometimes it was being reinforced and she was being able to vomit and other times she wasn't. And so I do think that there are considerations that need to be made when certain interventions can only be implemented in certain settings.
Right.
I
You know,
think, sorry,
Go
you go
on.
ahead, Alex.
Okay, I was going to say, just, maybe like we're saying, that big importance on case by case basis. Maybe it's not only the individual, but it's the settings as well, right? Because like we're saying, like the incident of an individual forced vomiting, you can't always implement the procedure that you want to. So, in the case of mechanical restraints, maybe if it can be used effectively in one setting, but not in another setting, okay, let's find the least restrictive but best alternative in different settings. And I think what we've agreed upon within the discussion is that, some individuals may need to use mechanical restraints. It can be ethical depending on the behavior, but for others, it's not ethical at all. So, it's, again, back to that case by case basis. I know we keep going back to it, but I think it's important.
I do agree with that, and that is actually what happened in this scenario. The parents were using a certain mechanical restraint chair for the child for other behaviors already, and they decided that that was the best option for at home.
When you go to bed, it's like... Sorry.
It's okay. Alex, will you type in right there what you want to say for that part, if you don't mind?
Sure.
Okay. Heather, are you?
So yeah, I just don't want to cut anyone off.
No, you're
So
fine.
going strong. So yeah, just kind of going back to what Hannah was saying about, these anecdotes where there's a child who does really well with some mechanical restraints at school, and like there might not be staffing for it at home necessarily, or like a child who lives in one state where they are able to have the restraints that are therapeutic for them, and then they move to another state where they don't. I think that is really brings us to an important point of knowing what are the alternatives to restraint, especially for instances like that where a child might not be able to access the restraint that their plan called for in another place, or that they don't have the staffing for from like in a different setting, like at home or a residential facility. So there's research from 2009 that mentioned 2 different antecedent interventions that have been very effective in preventing problem behavior from occurring. That's discriminative stimulus control and motivating operations. So I'll just talk about discriminative stimulus control. An example of this intervention would be to give the clients the ability to work better for high preferred therapists versus like a low preferred therapist. And I also think we can think of this as just like having instructor control over an environment in general, like in ABA speak. That's like what we would do just to set up all antecedent interventions to know, like a child knows the expectations, they know the contingencies, they're able to get things for being able to behave in a particular way.
I know we had a client that we actually used a similar strategy with, and they had like a picture book of all their therapists that they liked hanging out with, and really it was very rotating motivating operations. Sometimes it was a certain therapist, like the high preferred therapist would change all the time. So it was nice to have that book, and they could kind of pick out, and they, after it was on a CRO, but they would be able to pick out, like, I get to go spend 10 minutes with this therapist.
Right.
Kind of a cool strategy to use in that way.
Yeah, there's definitely something that is really effective. I mean, I've worked with kids where I always have great sessions with them, but another therapist has a hard time, and vice versa. So you really have to know who works best with them and how they work with them. And, if that can be a motivator for the client, why not utilize it?
Yes, I totally agree with Alex.
Are we on motivating operations now?
Yeah, I think so.
Yep.
So you're taking that section there?
Yeah. Okay. So knowing the client's MO for the behavior can definitely help, in preventing problem behaviors from occurring. So one example of this, would be to give the individual who is, so for instance, reinforced by attention, and having the staff that is working with that client throughout the day that would definitely decrease the chances of the client engaging in the problem behaviors in order to get attention from others. And also to add on to that, restraints and seclusion have been found to be effective when used in combination with other interventions such as contingency-based behavior programs, token economies, skill groups, all the above.
Sure. So it's not just that we use the restraint. It's pretty cool that the learning and the motivating operations that we think of for just general sessions, in combination with restraints and seclusion, they help as well, which is really cool.
Yeah.
Yeah, there's some research also talking about, Sprague was one of the authors on that, talking about PBIS used within schools or correctional facilities, which is just using positive behavior intervention strategies, and it was able to reduce the number of restraints. So if you look at our visual, there's a baseline of number of restraints from 2007 to 2009, average number of restraints per month. When they implemented, this was for a school-wide program. When they implemented that, there was a significant reduction in the use of restraints. So it's interesting to see how restraints and seclusion are still necessary. They were, they might say a necessary evil, but it's something that was needed for some students. But what we saw is when we had these other de-escalation techniques and clear expectations for the clients, clear expectations for the staff, they were able to reduce the number of restraints needed overall as an entire facility. Howes was also talking about a fixed time release, or doing only using seclusion or restraints for a certain number of minutes, essentially, or like in a correctional facility for a certain number of days for seclusion. And then once you've hit that point, it's basically saying, like, we know that there will be a mental deterioration of this individual should we go past this time. So helping to kind of avoid some of those risks, implementing these procedures as a facility.
Right.
Yeah. So, that's looking at it ethically and legally. How do we protect our organization, but how do we also protect our clients? First and foremost, what's actually going to harm the client, and how do we stop that from happening?
Yeah. So does anyone have any other thoughts on de-escalation techniques or alternatives for restraints and seclusion? Any personal experience you have with that?
Well, I definitely know from the different programs that I've been trained with, whether it be TCI, CPI, it's de-escalation is really at the forefront. It's almost as if these shouldn't be called restraint programs or restraint training techniques. It should just be like de-escalation programs, and restraint's just part of it. So I think it's really interesting that we think of these programs as restraint training, and that's what it is. But a lot of their information nowadays, especially seen from CPI, information that we saw earlier with our visuals, the de-escalation is one of the largest parts of how we keep ourselves and our clients safe, and to try to get them back to that baseline as quick as possible. I've had a variety of instances where just by being calm, maintaining myself properly, I've been able to get a client back down to baseline. There hasn't been a need for restraint, and that might not always be the case for individuals. Sometimes restraints need to occur, but it just shows that de-escalation works really well in hand with restraints, but it can be utilized alone to stop restraints altogether.
Okay, so sorry to go off the grid, but who do we want to wrap up? Do we have someone else to be like, here's the conclusion?
Yeah. Do we want to ask any other questions here, like as a final, like, okay, do we think, just to like jump back?
I don't know. Long. This is probably way over time, so I don't think we should add anything. Okay. I don't have the time right on my screen, so I'm not sure.
I think we're around an hour.
Yeah.
Has it been? Oh my God.
Yeah.
So we might even have to like cut out some stuff.
Yeah. Do you want to stop the recording now and see what it says time-wise?
Yeah, sure.